Hi, this is Jane O'Hanlon, consultant geriatrician, and I'm here with 5 slides on perioperative delirium. The first thing I want to say is that this is a really common condition, particularly in the older perioperative patient. It's also something that we miss a lot, so you've got to actively look for it. It's not just the agitated, confused patient that presents with delirium. It can be hypoactive, and you're going to miss most of those. So use a screening tool such as the 4AT. It's quick and it's very reliable. You can also use something like the CAM to diagnose delirium. And once you have diagnosed somebody with delirium, the next question is why do they have it? So generally, why does delirium happen? Well, there are two factors that are important. The first is their cognitive reserve. Do they have dementia or another condition such as mild cognitive impairment that have reduced their brain reserve and reduced their ability to respond to a stressor? And the second thing is the stressor itself. Now, once you have reduced cognitive reserve and an acute stressor, you get failure of normal brain function. There's a big long list of acute stressors. Most you'll be very familiar with, but it's common things on the surgical setting, such as postoperative pain, post-op hypoxia, infection, anemia, hypotension, environmental change, even, which can be something that sounds relatively mild, but just moving from one ward to another, or even just coming into hospital, withdrawal from alcohol, benzodiazepines, sleeping tablets they might be on at home, or cigarettes. Now, it's important for us to try and estimate both factors when we're treating a patient with delirium. So, the first question is the cognitive reserve. How good or bad is that? And there are a few different ways of getting a fairly subjective idea of somebody's cognitive reserve. If you've got a cognitive score, such as a MoCA, MMSE, AMTS, MiniCog, that'll give you a rough idea. You might also have to ask for a collateral history from their family. Are there any specific memory issues that have been identified? If you've got a head CT, you can look at that, even if it's from a few years ago, to see where there are white matter hypointensities on it, or are there other abnormalities such as atrophy or an old stroke, and all of those will increase the chances that they have a low cognitive reserve. The stressor itself, it's important to figure out how severe that is. So is there CRP, for example, over 300, something that's too high to be just a normal post-operative CRP in most cases? Are there O2 sats dropping down to the 80s? Is their hemoglobin level low? And remember, 8 isn't an actual cutoff. That's just somebody invented that at some stage. It could be that they came in with a hemoglobin of 14 and they've gone down to 10, and that's a huge change for somebody who has a low cognitive reserve. Is their blood pressure low? And remember also, most people we see are in bed, so their blood pressure might be 120/80 in bed, but as soon as they get out of bed, it'll probably drop down. Do they have very intense pain? Is there severity to their drug withdrawal? Do they have COVID-19? So it's important to try and figure out those things because they might have something obviously like undiagnosed dementia there that you haven't ever been aware of before. But also, if patients with good cognitive reserve, for example, you were to get delirium, then the stressor itself must be very bad. So you need to be really worried about patients that have a good cognitive reserve and become delirious. And a model for conceptualizing this in your head is to think of it as angina of the brain. Like angina, if you're called to that, it's clearly an emergency, but it can present atypically and it's often missed. The problem has to be fixed. So you need to find out what's the stressor, reduce that stressor, so treat the infection, give painkillers, treat the drug withdrawal, dehydration, whatever it is. Try and improve perfusion up to somebody's brain, particularly if they have low cognitive reserve. So give them oxygen, stop their antihypertensives, transfuse them. Those are suggestions depending on what you might find with the patient. But one thing is for certain, and that is that sedation is not an answer for delirium. While there are very rare cases where it might be necessary, if somebody is at risk to themselves or others, it doesn't fix the problem. It actually just masks it and usually it makes it worse. A word on undertreated pain, because this is a huge issue for people who have cognitive impairment of any sort. So anyone who's at risk of delirium, really, they need a personal, individualized assessment of their pain management. They should not be deprived of opiates as well. Avoiding opiates or using very low doses of opiates has been shown to actually increase the risk of delirium but yet there's an urban myth out there that confused people shouldn't have opiates. The opposite is true, so do not stop opiates in confused patients just because they're confused. Only stop if there's another reason to stop. Otherwise, lots of people with dementia or delirium won't get adequate pain relief. Oxycodone is very well tolerated in older people, even those with frailty, even those with some degree of kidney impairment. Whereas morphine, the older drug, tends to accumulate more readily in people that have chronic kidney disease. Don't forget to check if there are other reasons or sources for the pain, though. So, for example, you're seeing somebody post-op with a hip fracture and you're treating their hip pain, but actually they might be in pain because they've got urinary retention. And again, in patients with cognitive impairment, they can't really express that very well, so they might just become agitated. So that's something you need to proactively check for. So to summarize, you should screen for delirium. The 4AT is the easiest, and that's because we missed most cases of delirium. Think about cognitive reserve and think about stressors. Try to reduce the stressors instead of sedating patients. Keep looking for a cause until you find one, because there is always one. And then treat pain. So don't stop opiates just for confusion. Give older people with cognitive impairment a personalized pain management plan, because you actually might prevent delirium, and even if you don't prevent it, you might be able to reduce the length of time that they're delirious. Thank you very much.